Welcome everybody. We are gonna take a couple moments for folks to start joining us, but we're excited to have you and everybody else join us for this wonderful webinar today. So it starts at 3, so we still have 2 minutes, and we'll probably give it about a minute for everybody to join us. Hey everyone, thank you for joining us. For those that are just hopping in, we are going to take a minute or so to let everybody join us. We do have quite a few number of registrants for today's webinar, and so we're really excited. So we'll give it another minute or so. I guess in the meantime, please feel free to use the chat box and chat in where you're joining us from, what state, what organization. We'd love to hear where everybody's tuning in from. I see we got a lot of folks chatting in where they're joining us from, which is really great. We're going to go ahead and get started on today's webinar. Welcome everyone to today's webinar, Amplifying Birthworker Models of Care, a global solution to the growing maternal mortality crisis and its impact on the MCH workforce. We are really excited to have you all here today, and we're really thrilled to be having this conversation. My name is Salome Araya, and I'm the Perinatal Health Program Analyst for the Women's and Infant Health Team here at AMCHP. And so for those of you who don't know what AMCHP, or the Association for Maternal and Child Health Programs, is, it's a national resource partner and advocate for state public health leaders and others working to improve the health of women, children, youth, and families, including those with special healthcare needs. This webinar is the third in its series to be put on by AMCHP's Global Health Workgroup, titled Sharing Global Approaches, Creating Local Outcomes. And the focus of today's webinar will be on exploring successful global and local models of childbirth care, and sharing ways we can really adapt these models of care within our own local context. We're really thrilled for it, and I'm joined here with my colleagues Noelle Vasquez and Laura Powis, as well as our panelist speakers, Andrew Herrera, Wani, Mario, Chanel, Portia Albert, and Nick Pearson. And you'll be hearing more about who they are and what organizations they represent throughout this presentation. Next slide, please. So as mentioned, this is the third series in its global health initiative titled Sharing Global Approaches, Creating Local Outcomes, the MCH Global Health Webinar Series. And so really the commitment is to really identify and share culturally appropriate best practices, bright spots and insights from the global community, including US jurisdictions and tribal nations with Title V and its partners. Also to be sharing case studies featuring successful global health programs that can be implemented in the US, and expanding the MCH Innovations database to include global health practices. Next slide, please. So some quick little housekeeping details. All lines will be in listen only mode for this webinar. You can chat in the chat box throughout the webinar and make sure that you're sending it to all panelists and attendees. You can also send questions through the chat box, or you can click on the Q&A feature, which you'll see at the bottom of your page. Today's webinar will be recorded, and if you have any issues or technical difficulties, please feel free to email Laura Powis at lpowis@amchip.org. Next slide, please. So, in thinking about why this conversation, maternal mortality is a global health crisis. The Sustainable Development Goals, or SDGs, are a global health standard that was developed by the World Health Organization to really understand how our maternal and child healthcare systems are performing on a global and a local scale. And so specifically Target 3, which is good health and well-being, calls for a reduction and prevention of maternal mortality as well as neonatal mortality. And by 2030, Target 3 will ensure that universal healthcare access to sexual and reproductive healthcare services, including family planning, information, and education, are really at the forefront of these services. But with the impacts of COVID-19 coupled with the geographic and economic disparities that countries and nations experience, the majority of the global world are not really on track to meet their goal by 2030. And so if you click through this slide, we see that the World Health Organization created the 5 strategic objectives to guide program planning towards ending preventable maternal mortality. And so this is a guidance to provide nations with high mortality rates, and it really calls for a shift instead of focusing on emergency care to really focus on supportive and preventative care. It emphasizes availability, accessibility, acceptability, and the quality of services, and puts a human rights principles such as participation, information, and accountability at the forefront. And it also really prioritizes improving the quality of care and equity across facilities and community settings. And so you'll see on the slide, these are just some of the core components to ending and preventing maternal mortality. Next slide, please. And so when you look at this first map, which demonstrates and shows maternal mortality rates on a global scale, you would assume that with us being in the blue range, with the US being in the blue range, you would assume that compared to other nations and countries, that the US really seems to be meeting or on track to meet their Sustainable Development Goal Target 3 by 2030. However, if you click through and when we look deeper at these numbers, you'll see that, and this figure right here is showing the maternal mortality rates in the US from 2018 to 2020. And you'll see that we cannot remove ourselves as a nation from this conversation. The rates of maternal mortality across non-white Hispanic, across non-Hispanic white, non-Hispanic Black, and Hispanic has increased since 2018. And a lot of this can be contributed to COVID-19, as well as really the lack of quality of care that we are seeing within hospital settings and birth centers. And so this really shows that the current maternal mortality crisis in the US really demonstrates a need to integrate birth workers into health systems. And it's really opened us to look more into global solutions as MCH professionals. So this is going to be kind of a guiding question as we look through throughout the webinar of really how can we learn from global childbirth models of care. And so I'm going to pass it to my colleague Noelle, who's going to introduce herself and explain a little bit more about birth work.
Hi, everyone. So my name is Noelle Vasquez. I am on the evidence and implementation team here at AMCHP. And so for the next couple slides, we'll just talk about some of the common birth work titles and labels that we have. A lot of these terms are used interchangeably, particularly in the United States. But as we take a global approach and a global view of birth workers worldwide, we've learned that these roles can have different meanings. And so we've just outlined some of the common descriptions for some of these terms. So a midwife is someone who is medically trained and licensed to deliver babies. They can also prescribe certain drugs to their patients to help with pain. And they support both the mother and the baby. They're often present in the delivery of a baby when the mother comes to term. Doulas, on the other hand, are focused on the well-being of the mother, and they do a really great job at providing emotional support during and after the birth. And they also advocate on behalf of the mother, whether that be with pain management or with the mother's preferences across a variety of situations that the mother may encounter while she's pregnant and while giving birth and afterwards as well. And the last kind of common term that we hear when looking at the MCH workforce globally is community health / community birth workers, which are notable examples we find in India, where community health workers are the ones providing significant amount of antenatal care for pregnant women, as opposed to like doulas and midwives that we see here in the United States. And their education tends to be more well-rounded, allowing for them to service MCH patients. Next slide. So how can birth workers contribute to addressing maternal mortality crisis locally and globally? So we see that in the United States, birth workers help contribute to close the gap in racial disparities. Next, there's a couple more. Yeah, one more, Laura. They help close the gap in racial disparities. And so we see that doulas, right, which are blanketed under the term of birth workers, provide additional support that women of color in low-income communities often need. And we see this quote that says, expanding access to midwives and doulas, especially those who are part of the communities they support, can significantly improve the health and birthing outcomes and experiences of people of color and LGBTQ people. So doulas provide this kind of level of extra support because they are so in tune with the needs of mothers that are separate from traditional hospital settings. And so as we know, women of color tend to have lower quality of care. And so when doulas and midwives step in, they can help kind of pad that gap and provide them better support for their individual needs. And then India's community health workers, which is a scientific peer-reviewed journal paper that we looked at when putting together this presentation, showed that community health workers and their presence in the MCH fields in India have been shown to improve health outcomes amongst pregnant women, even though they aren't designated as doulas or that specific term, but just having them there and having their well-rounded education in that sphere of work has been helpful for meeting those SDG goals that Salome mentioned previously. Next slide. So why this overall conversation? The first one is to clarify the differences between doulas, midwives, and other birth workers across cultural contexts. This conversation is also helpful to share insights and lessons learned from global birth workers, as we'll see throughout the rest of the presentation, and the models of childbirth care efforts to inform and improve domestic work. So part of our global health series is to take lessons that we see worldwide and see how we can incorporate that into the work that we do. And so to gain insights and lessons about how global birth models can be adapted to the US domestic context, right? How can we integrate their work with the work that we're already doing? Can we change things? Can we better things? Things of that nature. Next slide.
Okay, I'll go ahead and introduce myself if that's okay. My name is Andrew Herrera, and I am the Executive Director of Cure Americas Global, based in Raleigh, North Carolina. And I'm here with my colleagues and personal heroes, Dr. Mario Valdez and Juani Valdez. Dr. Valdez is the Executive Director of the CASA MATERNA Cure Americas Guatemala project. He's been there for 20 plus years. Alongside him is Juani, who is the head nurse, and I'll be serving as the interpreter for Juani as she presents on their model in Guatemala. Next slide. Juani?
Buenas tardes a todos. Vamos a presentar lo que es el proyecto de organización y participación comunitaria e institucional en salud, atención de partos humanizados y respetados por Américas, Guatemala.
Good afternoon to everyone. Today I'm going to share about the organization and community participation for institutional health, birth, humanized birth, and respected birth in Cure Americas Guatemala.
Podemos observar el mapa de Guatemala, en donde están ubicados los proyectos. Tenemos el municipio de San Sebastián Coatán, San Miguel Acatán y Santa Eulalia en Huehuetenango, Tajumulco y Concepción Tutuapa en San Marcos y San Juan Atitán en Sololá.
Here you can see the map of Guatemala where we work in 3 municipalities in the Northwest Highlands: San Sebastián Coatán, Tajumulco, Concepción Tutuapa, San Marcos, and San Juan Atitlán, Sololá. So you can see those on the map here.
La siguiente.
Next slide. Sí, adelante, Juani.
Resultados de impacto, tenemos lo que la ubicación de las casas maternas. Tenemos en San Sebastián Coatán la de Calhuitz en el 2009, Santo Domingo, San Sebastián Coatán en el 2013, Tuzlasco ya San Miguel Acatán 2014, PET Santa Eulalia 2015, Pueblo Nuevo, Tajumulco 2017, Toquián Grande, Tajumulco 2018, Sichivilá, Concepción, Tutuapa 2020, que fue cuando se inauguró cada una de ellas.
Here you can see us scaling up our program across Guatemala. In 2009, we began with our first Casa Materna in Calhuitz, San Sebastián Coatán, and then we had a new Casa Materna in 2013, another one in 2014, and a new community in 2015, another community in 2017, 2018, and 2020. These are all Casa Maternas, or maternal homes, rural maternal homes in Guatemala.
La siguiente.
Next slide, please. Adelante, Juani.
Tenemos lo que es la estructura institucional y de funcionamiento del proyecto piloto de los territorios de Huehuetenango. Dentro de ellos podemos mencionar a Cure Americas Global, Cure Americas Guatemala, medicinas humanitarias, socios particulares que apoyan. Tenemos GWHS, que es el proyecto de ultrasonidos, municipalidades y Ministerio de Salud Pública, que son nuestros socios para la estructura y funcionamiento de estas casas maternas.
The Casa Materna Rural, the rural health maternal home, is in the center here, and you can see our institutional structure and how we've function with our pilot projects across different territories in the Western Highlands of Huehuetenango. Our partners include the US-based Cure Americas Global, our institution, Cure Americas Guatemala, other organizations who support us as donors, the local governments themselves, and the national and state Ministry of Health.
La siguiente, por favor.
Next slide, please. Adelante, Juan.
Pasamos a lo que es la producción trimestral de casas maternas, rurales de Huehuetenango y San Marcos. A partir de mayo del 2009, diciembre de 2021, nos podemos dar cuenta los trimestres que están de impacto, pues cómo inició y el total de octubre a diciembre del 2021, que fueron 165 partos atendidos.
This graph just represents the quarterly production of the rural maternity homes, the CASA maternas in Huehuetenango and San Marcos from May 2009 to December 2021. We've had 3,660 births in these rural maternity homes. And you can see in the most recent quarter ending December 2021, we had 165 births.
La siguiente.
Here, I will just read this quickly and then we'll have pictures to share. These are the achievements of the CASA Materna project, including access to healthcare services, a decrease in maternal and neonatal mortality, increase in community organization and participation in health facility deliveries or institutional deliveries compared to other healthcare services, an increase in percentage of women postpartum with 4 prenatal checkups, an increase in normal, natural, and humanized births, a decrease in unnecessary C-sections. We've increased family and community involvement and partner involvement from the local government and the Ministry of Health. Next slide, please. The way that we have achieved this, the strategies used by the leaders in Guatemala to achieve these goals include an implementation of learning circles where young women and pregnant women and nursing mothers come together each month to learn from each other and share lessons and challenges. We also ensure home visits to both the mother and the father so that they can make sure they can deliver at the facility, at the Casa Materna Rural. We include the midwife as a fundamental member of the healthcare team so that she can attend and support and lead at the Casa Materna Rural. We also make sure that there's a process of a culturally appropriate, respectful, and humanized childbirth. We involve the partners so that there are project sustainability long-term. Other partners, like we mentioned, Ministry of Health. There's also ongoing training of health personnel to improve the quality of care. Next slide. Additional strategies include these home visits to pregnant women to build trust with the staff and to ensure that there's a culturally appropriate, respectful, and humanized childbirth. We provide respect for the woman's autonomy during the birthing process. We ensure that there is ahead of time a birth plan. The mother completes a birth plan for respectful birth. After the birth, we ask her to evaluate. Did she get what she wanted? Did she have the birth that she had hoped for? So there's an evaluation of that birth plan. We also make sure that all maternity homes have the culturally appropriate facilities for women seeking the healthcare services. And there's ongoing both theory and practical training for midwives to ensure they have the skills and abilities they need to be successful. Next slide, please. Ahora usted, Juan.
Gracias, Andrés. Ahora vamos a darles a conocer lo que es el ambiente de las casas maternas rurales. En esta ocasión, pues vamos a presentar lo que son las cocinas, ¿verdad? Vemos aquí de que son cocinas muy sencillas, porque lo que nosotros queremos demostrar es de que la señora, la paciente que llegue, la parturienta, se sienta como en su casa y la familia también. Entonces crea confianza entre ella y el personal.
Here I'm showing the kitchen, the environment of the Casa Materna and the simple kitchens where the mother, the woman, the patient feels like she's at her own home to build trust between her family, and the staff at the Casa Materna.
La siguiente.
Next slide.
Tenemos lo que es la sala de partos. Pueden ustedes observar también como las tenemos decoradas con algunos carteles de información. Tenemos también nuestras pelotas en donde las mujeres pues realizan sus ejercicios antes de iniciar ya el proceso de expulsión. Tenemos también lo que es la silla, ¿verdad? Para poder ayudar a la parturienta a cómo ella desea tener. Y también
Juan cortó su señal tal vez el video. Vamos a ver qué tal señal. Here you can see the birth room where you can see how it is decorated and the information on the walls. You can see here the balls for exercise before labor, the chair and the rope so that the mother can choose what position she'd like to give labor. She'd like to give birth. Yeah. Next slide.
siguiente. Tenemos la sala del posparto, que es donde, pues, despuésito de, como su nombre lo dice, posparto, después de tener a la señora su bebé, pues es trasladada a esta sala para su recuperación, en donde el personal, pues, le brinda los cuidados posparto a la paciente y al recién nacido. Entonces, les damos a conocer lo que es nuestra sala de posparto.
This is the postpartum room where the woman is transported after birth so that staff can monitor and provide postpartum care.
La siguiente. Tenemos lo que es el CHUG y el servicio sanitario. El CHUG es le podemos llamar un sauna, un temazcal, en donde las parturientas pues lo utilizan en algunas casas, según la cultura, pues es antes del parto. Esto ayuda a relajar a la mujer al momento del parto y en otras pues después del parto, y también esto le ayuda a la parturienta a lo que es a disminuir la hemorragia. Entonces, ellas solicitan y nosotros pues les damos ahí sí que la opción al CHUG antes o después del parto.
Here you can see the facilities available to the mother. On the left, obviously on the right, there's the bathroom, but on the left, there's also a traditional sauna called a CHUJ, C-H-U-J. That sauna is available. It's what is traditionally used for bathing in the Mayan homes where we work. And in our homes, the mother can choose before to relax. She can choose to have her sauna or her CHUJ or afterwards as her choice, as her preferences, and to also reduce hemorrhaging. The sauna is a key part of the culture and the communities where we work.
La siguiente. Tenemos lo que es la clínica para la atención de consultas. En esta clínica, pues nosotros al ingresar la paciente, nosotros le hacemos su evaluación correspondiente para posteriormente, pues, decidir si ella va a ser ingresada a la casa materna para la atención de su parto o si es trasladada a un hospital o a un nivel de mayor resolución.
Here is our consulting clinic where we can provide basic services to the mother before birth to also decide if the mother will be admitted to the CASA MATERNA or if it's necessary to transfer her to a higher level facility for any complications.
La siguiente, por favor. El parto con pertinencia cultural se centra en un conjunto de conocimientos y acciones durante el proceso del parto según la cultura maya, en el caso de Guatemala, que incluye elegir el lugar donde desea que se le atienda su parto. Se le proporciona un té cuando ella ingresa al servicio de casa materna rural o despuesito del parto. Ella decide quién la acompañará durante el proceso del parto, el respeto a su vestimenta. Ella elige la posición del parto y otras prácticas adecuadas a su cultura. Ella y su familia tienen derecho a sus oraciones o ritos que deseen según la cultura que ellos tengan.
Here we have the definition of a culturally pertinent birth, where the knowledge, actions during birth are according to the local culture. For us in the Mayan Guatemalan communities, that includes that the woman can choose where she'd like to have her birth. She receives a local tea when she comes in for service at the Casa Materna. She chooses who gets to join her during the birth process, her husband or family members or midwife. We respect the clothing that she chooses to wear. She chooses what position for the birth and any other cultural practices. And her family have the right to any prayers or rituals they'd like to perform with the mother.
La siguiente, por favor. Tenemos lo que es la atención del parto con pertinencia cultural en las casas maternas. Nos podemos dar cuenta de que ahí la mujer es la que decide cómo va a tener a su bebé. Hay varias posiciones, pero ella es la que elige y pues ahí sí que con ayuda de la comadrona, que es ahí sí que el pilar importante para nuestras casas maternas, y el personal, pues ella es la que va ahí sí que es la protagonista para el proceso del parto.
Here we can see the mother choosing different positions. There are many positions, and she is assisted by her midwife, which the midwife is an important pillar of our program, so that we can have the mother always stay as the protagonist of the birth process. Next slide.
La siguiente. Tenemos el acompañamiento de la pareja durante el proceso del parto. Es muy importante el acompañamiento del esposo. Ella también decide si desea que el esposo la acompañe y nosotros pues respetamos lo que la parturienta nos indique. También muy importante el acompañamiento del personal y la familia durante el proceso del parto, pues esto ayuda a que ella el proceso lo asimile más rápido y pues se dé lo más natural el parto.
Estamos en 15 minutos, Juani, para pisarle. Here you can see the husband joining the birth process. Is important for family and for the mother to be able to choose who is there with her. And again, another example of her having all of the control of her birth process. Next slide.
La siguiente. Tenemos el respeto a su vestimenta.
Respecting and allowing the mother to wear whatever she feels comfortable with.
La
Next
siguiente.
slide.
Ella elige la posición para la atención de su parto.
Another example of choosing the position for her birth.
La siguiente. Administración de un té natural a puérperas dentro de las primeras horas después del parto o antes del parto.
As the woman prefers natural teas right after birth, postpartum, or before.
La siguiente.
Si quiero, Juana, yo puedo leer eso en inglés.
Sí, mejor, Andrés.
For time's sake, I'll go ahead and just interpret this into English. The humanized and respectful birth for us is a key term that refers to the rights of the mother, the little boys and little girls and families at the moment of birth. We promote the respect of every family because each family is different with ethnicity, religion, and nationality, who can accompany them and take the decisions as the mother. The respectful birth implies the generation of space for the family where the mother and the newborn are the protagonists, and where the birth is the birth is implemented in the most natural way possible. Excuse me. When we talk about the respectful birth, it refers to a mother who. Sorry, the chat. When we refer to a birth, it's about a mother who is avoiding the unnecessary interventions, where she can decide and control the pain for her birth. Next slide, please. Additional photos here. Tal vez sigamos a los tablas.
Vemos lo que es la atención del parto humanizado en las casas maternas, algunas fotografías de lo que es la atención que se brinda en los servicios.
Here are some examples of the attention provided with respectful and humanized births in the CASA maternas. Next slide.
La siguiente. Tenemos lo que es el apego inmediato, el corte tardío del cordón umbilical.
We have the immediate breastfeeding and cord care.
La siguiente. Tenemos lo que es la capacitación continua a nuestras comadronas, es muy importante, ¿verdad? Se da lo teórico y para posteriormente lo práctico dentro de las casas maternas.
The ongoing training of midwives, both theory and practice, is a key pillar of our program.
La siguiente. Tenemos lo que es el trabajo en equipo con comadronas durante el proceso del parto en las casas maternas.
Here's us working hand in hand as a team with the midwives and the staff of the Casa Materna.
La siguiente. Tenemos lo que es resultados de impacto. Podemos observar ahí lo que es en color azul el parto institucional antes de funcionar cada casa materna, y el rojo, pues, perdón, el color naranja, el parto institucional cuando ya funcionaban las casas hasta octubre de 2021.
A key indicator for us is health facility births, and the Ministry of Health tracks this. You can see in blue in each community the number of births before our Casa Materna Rural was present, and then the number of births in October of 2021 in orange after the Casa Materna was functioning. These are the difference in number of health facility deliveries.
La siguiente, por favor. Tenemos resultados de impacto en comparación con los centros de atención permanente, CAPS y Ministerio de Salud Pública y Asistencia Social. Pues el color amarillo podemos ver los partos en casas maternas rurales de los trimestres del 2021, enero, marzo, abril, julio, agosto a septiembre, y podemos observar los del color rojo, que son los del CAP.
You can see here the difference between the government health facilities, their frontline clinics in orange versus the Casa Maternas. These are community-owned, privately operated community clinics in yellow. And you can see the difference in the number of births. Orange is government, yellow is the Casa Materna, the community-owned clinics.
La siguiente. Tenemos el porcentaje de puérperas que en su último embarazo elaboró, escribió su plan de parto. En cada una de las casas maternas, pues la parturienta o la embarazada, perdón, escribe un plan de parto respetado y estos son los resultados que tenemos.
This is just data from each Casa Materna on the number of women in their last birth who had a birth plan for respectful care. As you can see, in the total at the end is 93% of all the Casa Maternas of the women had a birth plan.
La siguiente, por favor. Tenemos anteriormente representamos lo que es que ella escribe su plan de parto, aquí que manifiestan haber tenido un plan de parto respetado. Entonces, se tiene un total del 91% del proyecto de cada una de las casas maternas.
So the number of women before were who wrote a plan, and this is the number of those women who followed their plan, 91%.
La siguiente, por favor.
We'll throw this in the chat. These are the links for reading additional and a couple of YouTube videos as well.
Y estos son los enlaces que sostienen esta experiencia. Podemos verlo ahí y muchas gracias.
Thank you so much, and we'll share the links with you.
Thank you so much, Wani and Andrew, for that wonderful presentation and really just sharing so much of the great work that CASA Materna is doing in Guatemala. Next slide. We're gonna go to the next speaker, Nick Pearson, who is the founder and co-executive director of Jacaranda Health and also holds an adjunct faculty position at Duke University's Duke Global Health Institute. Nick has worked at the intersection of business and global health in East Africa, Vietnam, and India, and he'll be sharing more about Jacaranda's health partnership in Kenya to improve maternal and child health care access and delivery. And so with that, Nick, I will pass it on to you.
Hey everyone, it is a pleasure to see you all, and thank you for inviting me to join this conversation. I saw in the chat the sort of broad diversity of participants from all over the country, and really exciting to see sort of folks who are doing all this important work in various states here joining the conversation. So you can advance to the next slide. I'm going to talk a little bit today about the work that we do in Kenya at Jacaranda Health, and also tie it back a little bit to some of the work that we've been doing in the United States as well. I'm based in Chapel Hill, North Carolina. I saw a few of you from North Carolina in the chat. And so hi there. My wife is an obstetrician here at Duke. But Jacaranda Health is primarily based in Nairobi, Kenya. All of my colleagues are there. I'm here for family reasons. But we are an organization, and you can advance to the next slide. We're a nonprofit organization focused on improving maternal health outcomes in East Africa, first and foremost. And our kind of vision is really around a world where all moms can experience childbirth safely and with respect. And so we've been working for the last 10 years in Nairobi, Kenya, and we actually got our start, interestingly, as a maternal health services provider. We set up midwife-led birth centers and hospitals that were focused on providing high quality, low cost, affordable services that were respectful to moms living in the peri-urban parts of Nairobi. So we actually have spun that out into a sister organization. We have 3 really busy, well-loved hospitals that are kind of operating and continuing to serve moms in the Nairobi area. And that mission is expanding, but we realized that over time, in a country like Kenya, 80% of moms are delivering in government hospitals or going through the public health system. You know, the translation to the States would be if 80% of moms are covered by Medicaid and getting their care in county health departments, that would be the equivalent. And so, that's where a lot of the challenge and the impact needs to be. And so we found that some of the innovations that we had developed in sort of delivering our own services were adaptable and of interest to government partners, local government partners in particular in Kenya. And so we've, the focus of our nonprofit for the last handful of years has really been to work with partner governments. These are sort of local government entities in Kenya to deploy some of these solutions to address challenges in maternal health and do it in a sustainable and scalable and respectful way. Next slide, please. I won't go into the background. I think Salome did a nice job introducing some of the global challenges around maternal health, and most of you as professionals are familiar with this. But suffice to say that there's a big gaps in terms of quality of care and opportunities to improve services, outcome, respectful care, etc. Next slide. in particular in Kenya, and this is not atypical, I think, in a lot of countries, two of the biggest drivers of poor maternal outcomes and neonatal outcomes are around sort of delays in care seeking, getting to the hospital in time when emergencies or complications emerge, and the sort of knowledge around care seeking, as well as quality of care, intrapartum care in facilities. So this is sort of gaps in knowledge or gaps in practice among frontline providers. And Jacaranda's, you can move to the next slide. Jacaranda is really focused on addressing those two key barriers with our programs. And so we have two primary programs. We work, across a variety of areas, but the sort of two biggest programs that we have are, one, to address the sort of delays in care seeking. And this is a digital health platform called Prompts that empowers moms to kind of amplify their voices in the health system and also reduce delays in accessing care. And the second one is around training frontline providers, the sort of nurses and midwives who deliver most of the babies in public hospitals, with kind of mentorship skills, key emergency obstetric skills, and trying to do that in a sustainable and cost-effective way. And so we deploy those two programs in parallel, and they address these two kind of key drivers of poor outcomes. And we do it in partnership with government providers, both in and out of health facilities. The last piece that I think is worth mentioning is that, over the course of kind of growing and building these relationships with governments, we are generating a lot of data, both reported from mothers themselves, as well as from the frontline nurses and through the health system. And so increasingly, we're playing a role sort of working with government partners to sort of empower them to make sort of smarter, more equitable decisions in their health system around how they're allocating maternal health resources, and sort of deliver their care more respectfully and better. So I will talk primarily about the Prompts program, because I think that's the most sort of relevant at the moment, but always happy to sort of answer a question about the mentorship program, which focuses on frontline nurses and midwives. Next slide, please. This is just a quick snapshot of sort of the scale that we're operating at in Kenya. So now we're working with 20 county governments across the country. So we have over 1 million moms enrolled in this digital health platform. We're working in over 1,000 sort of government health centers and hospitals. The mentorship program is primarily active in the larger facilities, and about 200 larger facilities where most of the births are, where most moms go to deliver their babies. And we're working with several thousand frontline nurse midwives as well. So, impacting almost half of the births in the country, and growing to sort of operate over the course of the next year or two at a national scale, looking at other countries in sub-Saharan Africa as well as to partner. Next slide, please. Sorry, yeah, well, backtracking a little bit, but to give you, sorry, the next slide. And just as a quick high level, and we've been able to, we measure, we have a very data oriented team, and we spend a lot of time evaluating the impact of the programs and looking at kind of ways that the programs were, and there's a lot that I can unpack around things like changes in health seeking behaviors and nurse performance and things like that. But at a high level, two of the sort of most exciting data points are the fact that we're seeing a reduction in key maternal morbidities and complications like postpartum hemorrhage, and also reductions in newborn mortality in government facilities. So that's exciting to see at a sort of a large scale. Next slide, please. So the Prompts program is the one that I'll talk a little bit more about, because it ties into the work that we were doing here in North Carolina in the States. The idea here is it's a very sort of simple and straightforward platform, but it's an SMS-based platform. Moms enroll who are going in and getting their prenatal care in public health facilities enroll for free. It's a free program for anyone in the country who can enroll. And they enroll in a series of sort of messages over the course of their pregnancy in the first year of the baby's life. And it's probably familiar to those of you who are familiar with like Text for Baby and things like that. It's, similarly rooted in that same concept that, more information can be empowering and can help. But it's evolved into something that's a lot more than just sort of push SMSs and information. So what's happened is that we have these sort of very tailored, culturally specific kind of nudge messages that are really aimed at trying to kind of influence key behaviors over the course of pregnancy and the first year of the baby's life. And And so those have been kind of designed to sort of interact with moms as they're on their journey through the health system. And then it's also evolved into this sort of two-way service. So moms, we have a centralized clinical help desk where any mom anywhere in the country can text in questions about care, about questions they have about pregnancy, and it can range from simple things like what to eat versus, I'm concerned about this symptom that I have. And we're getting, 4,000 questions a day, so really high volume. And our team will respond to those. And it's now sort of evolved so that we have a kind of a fairly sophisticated AI on the back end that's helping to answer those questions. Not so much, there's still people interposed because we don't want to sort of risk missing potentially dangerous or challenging symptoms, but the idea is that it's sort of serving up responses and also helping to triage some of the responses that come in. And so what ends up happening is that through the system, moms are going through their journey, and it's informing and sort of improving uptake of some of these key behaviors. There's some on the statistics on the right-hand side of the slide to talk about how, how we've managed to see sort of changes in uptake of, key points, decision points in the journey. But it also helps kind of triage and identify potentially risky, high-risk births or, emergencies that are arising. And so we end up connecting those to care in the facilities that if someone, if an emergency does arise, we're able to connect them to care in the public health facilities that are nearest to them. Next slide, please. What this has also enabled us to do, I mentioned sort of data sharing with government partners, is it generates a huge amount of data, not just for its own sake, but I think what we're really excited about is the opportunity to sort of take what we're hearing from mothers directly and help influence quality of care and kind of respectful care in the health system itself. And so what we're able to do is we kind of co-design these dashboards with our government partners to look at things like reported quality of care issues that are coming from the mothers who are experiencing care, things like whether moms, we survey all the moms who are on the platform to hear whether they receive respectful care or not during their delivery, and we're able to sort of disaggregate that and share it back with the county governments, et cetera. And then also kind of link this up with some of the data that's coming out of the sort of frontline nurses who are sitting in the facilities training and sort of debriefing on the deliveries that they go through. So it's really a sort of an opportunity to create a really powerful data sets that can help deploy resources in a smarter way, hotspot. You can flip to the next slide, and there's a couple of examples of this sort of hotspotting data to help deploy resources smarter. So on the left-hand side, there's a couple of examples of like how amplifying moms' voices can help improve quality of care. So, with one of the counties we were working with, we, found that in one sub-county in certain facilities, moms were saying that they weren't experiencing sort of respectful care, either stigma or a lack of privacy, things like that. And we were able to share that data back, and the county ended up going through sort of quality improvement exercises to sort of boost those ratings, which was exciting to see. And similarly, both during COVID and then with things like infant vaccination, we've been able to identify where moms are reporting not getting certain key services like infant immunizations in the immediate postpartum period. So, this is something I could talk about for hours. It's interesting stuff for those of you who are more data oriented, but I'll skip ahead. And I think that what's interesting, for us also from the perspective of, for those of you who are here in the States, is being able to translate some of these lessons to the States. As I mentioned, I'm in North Carolina, really passionate about maternal health here, some of the challenges that we face across the States in terms of sort of inequities, disparities in care, inefficiencies, costs, et cetera. And when COVID came around here in the States, we realized that, there was, as all of you know, as all of you have kind of lived through, it created a lot more, it sort of exacerbated a lot of the existing disparities. It created a lot more barriers and challenges for expecting parents who are navigating the health system. And we saw that particularly here in North Carolina. And so one of the things that we thought we could do, just with a very small sort of pilot grant from one of our board members and a few other folks, we set up a helpline here in North Carolina called Birth Compass. It was originally called COVID Moms, and then we made it more inclusive by calling it Birth Compass. And the idea was to sort of take some of the pieces of that prompts program that I just described, not the sort of complicated high level like data stuff, because we don't have the kind of volumes for that, but just the simple, we assembled a team of sort of frontline birth workers, lactation consultants, doulas, et cetera, who were able to remotely respond to questions that were coming in from moms across the states and expecting parents across the state, and made it freely accessible to folks on Facebook, on text, et cetera. Next slide, please. And so you can we were advertising on Facebook, generating a lot of interest in ads, both in Spanish and English, with the goal of reaching folks who are sort of falling through the cracks or experiencing challenges navigating care, whether it was accessing Medicaid, or whether it was folks who were uninsured, or whether it was people who had questions around housing insecurity or domestic violence, etc. And so I'm not going to talk too much about this because I think Chanel is with us, and she'll talk in more detail about the work, our partnership in New York, which has some similarities, and she can talk about the sort of mechanics of this in a little more detail. But next slide, please. Just as a quick kind of a recap, we were able to look at sort of across thousands of conversations with mothers in North Carolina, some of the different kinds of sort of unpack some of the different kinds of challenges that we were seeing that mothers were experiencing in their journey. Next slide. And also get a little bit of an insight of the sort of breadth. So we're reaching people both, urban parents, rural, folks who are living in obstetric deserts in rural North Carolina, western and eastern North Carolina, as well as folks who are experiencing challenges culturally or for language gaps. I think maybe I'll stop in the interest of time. I'll stop. You can go to the next slide. And I'll leave it there. But I do think, one of the things, just reflecting on this a little bit, I mean, this is something that I'm really passionate about. And I think there's a lot of opportunity for those of us here in the States to learn from some of these international examples. Obviously, some of it has to be translated through the filter of a very different health system that we have here. So, the payment and insurer landscape is like super complicated here in the States. And that was one of the big things. And obviously there's a lot of cultural differences in terms of how people access care, differences in the health workforce here. But nevertheless, I think there's some fundamental principles that do hold true across geographies. And I think there's a lot to learn. Oftentimes here in the healthcare system in the States, we tend to be a little bit exceptionalist and think, well, everything's different in the States, so we can't learn a lot from overseas. But I think those of you who are joining the call kind of recognize that there are opportunities to learn, both in terms of, commitment to equity, which I think, in a place like Kenya, the government has said, we're going to make maternity services free for all women in public hospitals, which is a huge commitment that we can't seem to quite get right in most of the states, and would do a lot to sort of make good maternity care more accessible and more equitable. To things like costs, focus on cost effectiveness, cost efficiency, culturally concordant care, and designing really with sort of mom's cultural needs in mind, as well as the sort of frontline providers and birth workers, and some of the learnings that we can get from health workers and sort of different cadres of health workforce in other countries. I think, COVID has really underscored that for a lot of us, that, hey, some of these countries that have really built a strong community health workforce were better able to respond to some of these sort of pandemic type challenges. And, we need to invest here in the States in better cadres of doulas, of perinatal health workers, community health workers, to really be able to respond and sort of meet people where they are in the community. I will stop there. Really happy to answer more questions or share more with anyone here, but would love to sort of pass it over to Chanel if she's here.
Yeah, thank you so much, Nick, for that wonderful presentation, and also just for sharing the need to incorporate birth workers into more healthcare spaces. Chanel is not able to join us today, but I will still share. Oh, she's here. Yay, she made it. Okay, well, great. I will also introduce Chanel next, who is the founder of Ancient Song Doula Services and has been working within infant and maternal health since 2008. Her organization is focused on bringing full spectrum doula services and classes to those who are often overlooked within marginalized communities and communities of color, in an effort to really address the disproportionately high infant and maternal mortality rates among African-American women in New York City and New Jersey. She's also contributed to global work in reproductive health and is a maternal health strategist and board member of Village Birth International, and has attended over 100 births. She will be sharing more about her experiences as a birth worker and her partnership work with JustBirth Space. So I will hand it over to you, Chanel. And if you want to unmute your, oh, great.
Greetings, everyone. Hi, hoping that you are well and centered this afternoon. Again, my name is Chanel Porche Albert, and I look forward to speaking with you this afternoon. Next slide, please. And so I'm going to talk to you a little bit about JustBirth Space, and JustBirth Space is a perinatal support line supporting people amidst the COVID-19 emergency. Next slide, please. And so JustBirth Space is supporting pregnant people amidst COVID-19 emergency, and we provide free, just, and responsive virtual support to individuals in New York and Northern New Jersey to navigate pregnancy, birth, and the postpartum period. Our work is based on a collaboration, next slide, please, with other partners such as Village Birth International, Every Mother Counts, and Jacaranda Health. And so during the height of the pandemic, we were able to partner with Nick and Jacaranda to be able to create a platform that was very intersectional. Next slide, please. And so when I mean intersectional, I'm talking about what it means to really lift up a birth justice and reproductive justice framework within a text line. And so we incorporate specific core values that are centered in anti-racism and equity, accountability, that was most of us have probably encountered when we go into a text space. And so wanting to incorporate it was culturally congruent. And so understanding of racism and discrimination, but also how that plays out in a text space. It's rooted in intersecting with reproductive justice framework. And so really wanting to center the bodily autonomy and informed consent throughout the platform. And we center the culture of care in recognizing the intersections of health and racial equity while uplifting BIPOC leadership and community-based models. And you'll see that as I go through the presentation and really talking about how our connectors play a huge role in the impact on how we're able to serve folks. And we're addressing intergenerational trauma and people of color and centering intergenerational hope. And again, it's really centered on that bodily autonomy, informed consent, and promoting respectful care, respectful maternity care to folks as a additive. And again, this came out of a particular need at the height of the pandemic when, folks didn't necessarily have access to having a doula be present at their during a prenatal or at a birth or during the postpartum period in person due to the fact that hospital restrictions, right? And folks not necessarily understanding COVID and those things. Next slide, please. And so again, in our core values is really lifting up an anti-racism and equity. And so the practice is not a destination, acknowledging the current crisis in maternal and perinatal health as a result of racism, not race, and creating equitable models that are really based on trust-based solutions. Centering accountability, and so upholding self-accountability and community accountability and shared core values. And so what it really means for us to center equity, anti-racism, and then really having a shared commitment to inclusion. And so we commit to respecting individuals' pronouns, names, and express identities, including their choice to disclose or not to disclose, and will not make assumptions based on one's identity. And so again, understanding like people are at the intersections of care. We may be working with someone who's undocumented. We may be working with someone who has experienced domestic violence. We may be working with someone who is in the process of, we've had folks who have texted in who are currently in labor, right? And maybe they don't want to disclose certain information, giving them an opportunity to really feel safe in the platform and setting the groundwork for what does it mean to translate that human connection, that bodily autonomy, that respectful care at birth in a tech space. Next slide, please. And so basically it's operationalizing birth justice. And I'm sure that a lot of us have heard about birth equity and birth justice models, but we're really adapting a virtual perinatal support platform to community-based models of care, right? And this is happening again within New York City and Northern New Jersey. And that happens through recruiting a team of community-based racial, everything that we do. Next slide.
We lost you for a bit there, Chanel. What was that at the end?
No, as I said, all of this happens in really operationalizing this by incorporating that birth justice, racial equity, and anti-racist frameworks into an actual tech platform. Next slide. No problem. And that's where we have the intersections and the overlaps of health systems, referral partners, incorporating that birth justice, and then we have JustBirth space. So where, you know, your average provider doesn't necessarily have time, maybe they have 10 minutes to spend with someone in the clinic or while they're doing your prenatal. This is offering that continuity of care. This is offering them the opportunity to really be able to say, hey, here's a place where you can go and you can tap into. And it's going to really uphold, you know, a know your rights framework, a respectful care at birth framework. And it's all of us working together as a team to make sure that we have the best birth outcome, not just talking about like a healthy child and a healthy parent, but also how did someone feel within their care? Next slide. And that's done through our 3 circles of support. And so we have a text connect, and that's where people can text in from 8 a.m. to 10 p.m. Asking any kind of questions related to COVID, hospital-based policies. Maybe it's around breast or chest feeding. Maybe it's centering, asking about pediatric visits. Most recently, we've had a lot of folks who were asking questions about their symptoms, you know, about preeclampsia. If it's what I'm feeling, is this what it is? And we've been really able to help folks to intersect and say, listen, like you need to call your provider right now. And it saved folks a lot of, we hope, a lot of confusion that may come around when you can't necessarily access care directly from your provider. We have We Connect, so in the event that, you know, there's something that has to get bumped up, we have an opportunity to do phone and video support sessions and answer any questions in a more in-depth way. And then we have Community Connects. And so these are our virtual support groups where we build community during a period of isolation. So, you know, we're thinking about the postpartum period. We're thinking about how people are oftentimes isolated. You know, although you may have support of family members, it's still not the same kind of support that you would get from having like a lactation support right at hand, having that childbirth education, having someone that you can just text really quickly who's offering that non-judgmental support from a full spectrum reproductive justice perspective, and you know, at any given moment. Next slide, please. And this is just a forward-facing view of what the journey looks like on the user end. And so they'll text in, you know, with your question, and they will get an automatic generated response, but then a specialist comes on automatically. So they can add as much information as possible or as little information as possible. And each connector greets every person in a different way. Some people may say greetings, some folks may be saying peace. So, you know, someone may say good dawning as a way to be able to like really bring in this, move away from bots. And like, you know, I'm sure we've all dealt with when you're calling in and you're like, you know, I really wish I could speak to a real person. But knowing that, you know, you provide your zip code and then there you go. And then it's up to the individual how much information they want to disclose or they don't. Next slide, please. And some of the questions that we're getting asked, are, we're connecting with other pregnant people, new families, and community support. We're providing resources on your rights during pregnancy and throughout the spectrum of your reproductive health. COVID-19, we're helping folks to adapt birth plans. We're working with local hospitals around their COVID policies, but also their doula policies. And so really staying up to date, and we have a knowledge base to be able to support that. How to navigate insurance and Medicaid, how to access local social services, and also making sure that those services are relevant to the individual who's seeking them out, right? And then we're finding providers who are centrally focused on, and serve communities that are Black, Indigenous, people of color, LGBTQIA+, and inclusive and affirming. Next slide, please. And so this is just a snapshot of some of the community offerings that we have offered in the past, and this has actually grown. So the platform currently right now is in English and in Spanish. And our postpartum group is probably one of the biggest groups that we have at any given time. There's about 40 participants plus a month. And their group has expanded so much that now they have a WhatsApp group, and like they're meeting up in the park and they're supporting each other, outside of just the tech space. We have childbirth education, infant feeding, art as a meditation, prenatal yoga, a birth trauma support group, a know your rights support group, childbirth education classes in English and in Spanish. And all of these, offerings are completely free to the participant. And so you can go in as many times as you want to, or you can take a class as many times as you want to, or you can say, hey, you know what? I'm just gonna go in this one time and then I'm not gonna come back. But it's totally up to the participant. And it's a way for us to be able to create a network of support, to understand that when you've just had a baby, people are going through different iterations of how they may be feeling during that time. Sometimes you want to be close and really be centered around other folks, and sometimes you don't. And so we're really understanding of that. Next slide, please. Excuse me. And our platform wouldn't be anything without our connectors. And so our JustBirth Space connectors are wonderful individuals who are an interdisciplinary team of experienced community-based doulas, lactation counselors, childbirth educators, sex educators, postpartum specialists, and they're offering emotional and informational support in how to navigate systems, and often systems that oftentimes have not been friendly to Black and Brown and Indigenous people. They're offering localized support and referrals. They're warm and welcoming interactions. And again, that communication is happening in English and in Spanish, and we're looking to expand that. And it's always live support, 24, from 8 a.m. to 10 p.m. Next slide, please. This is just a snapshot of our comprehensive knowledge base. And so it is really, robust with over 2,000 plus resources and referrals and information for our connectors. And again, based on like COVID-19 hospital policies, creating a database that is including community support, rights, navigating insurance, so as things are consistently evolving, as they're changing, as we know, we're meeting the demand of the community as it ebbs and flows, right? And so if they were looking for resources for mutual aid, oh, I need diapers, most recently, of course, because of the formula shortage, being able to connect folks to resources to be able to access that, right? What does it mean for someone to be able to do that in a safe way where they don't feel like they have to do jump through leaps and bounds in order to be able to get the services and the goods that they need in order to sustain themselves and their families. Next slide, please. And this is just a snapshot of some of the incoming messages that we've received, such as I'm interested in receiving emotional support over text and I'm currently pregnant. Someone saying, I'm pregnant and preparing for my hospital bag. Is it okay to dry the baby's clothes in a dryer? Excuse me. Do you know how I can get an insurance card for my baby? Do I need one before the birth? I'm a first-time mom. I'm really scared because I was born at 23 weeks gestation. You know, can you offer me support? And how do I know if I'm going into labor? Is there any breathing methods that can help me during my labor? And so this is just some of them. Again, most recently, we had someone who texted in who we had been speaking to for some time, who had been experiencing signs of preeclampsia. And in every iteration in which we spoke to them, you know, we talked to them about signs and symptoms and, you know, speaking to their healthcare provider and really approaching the situation and asking a lot of questions. And last week, that same individual, you know, in their experience, you know, they reached out, they're like, listen, I'm feeling severely dizzy. We were like, you know, call 911 right away, right now, because her blood pressure was so high. They ended up medevacing her out of her home and getting her the support that she needed. And so again, like, we see this as really being able to offer that continuity of care that folks don't necessarily always get, you know, and we don't know whether it's necessarily on the side of the provider not necessarily being able to connect, or maybe she was just afraid or didn't necessarily feel like she had the support, but she did feel confident enough to reach out to us and to ask questions, you know. And again, we're not medical providers, but we'll definitely say, like, in situations, you know, you need to speak, you know, you need to call your medical provider right now. You need to, like, you know, boost this up to another level. And this is really serious. Next slide, please. And again, you know, the way the platform is really able to be successful is through our network of referral partners. And so, you know, it really helps us in building and formalizing partnerships with hospitals, health systems, organizations, and community-based groups. Again, we understand how racism and biases can present itself in healthcare. And so we're really wanting to ensure the safety of the individuals who are accessing the platform, right? And so we're, through our support referral partnerships, you know, we're alleviating capacity issues and providing clients with a space to ask follow-up questions, receive support, and gather additional resources, combating that isolation, really encouraging a collaborative care framework. I mean, I know we talk about it a lot, but we really want to be intentional about breaking silos within the system of healthcare, and creating a network for referrals across the spectrum of maternal health. And again, something that is really trusted support and client satisfaction. So being grounded in that human rights framework, being grounded in that birth justice framework, being grounded in an inclusive model is really what makes it a just space, right? For folks to be able to tap into and use it as a resource and makes them want to continue to come back. So we've literally had folks who, like, from the beginning of their pregnancy have been, you know, we've been following them. They've been, you know, tapping in and speaking to different folks, to the point where they go into labor, and now they're in labor and we're texting and we're, you know, offering support. And sometimes that support, depending on where someone is, if they have, you know, support, may translate into us actually meeting them in real time and supporting them at bedside. Excuse me. Next slide, please. All right. And so, you know, again, JustBirth space, you know, really came from really wanting to create a perinatal space that is just that. It's just, it's affirming. It's meeting people where they are, not where we expect them to be. It's inclusive. And it's really a collaborative process. You know, my partner, my co-director, M.A. Brill, has been really, you know, it's been a fantastic partnership to really be able to take a platform that has been used in Kenya to support folks from a global perspective and really adapt that to a US, you know, framework to be able to support folks in the way that feels good to them. Thank you.
Thank you so much, Chanel, for that wonderful presentation. Now we're going to go into the Q&A portion of this. And so this is a time where if you have any questions for any of our speakers, Chanel, Nick, Wani, or Andrew, this is your time to chat in some of those questions. I know that we had a couple that came in the chat. And so just to kind of start us off in thinking about the impacts of COVID-19, how has COVID impacted your work, and what adaptations did you need to make as a result of it?
I guess I could go. I would say in terms of our work, really having to pivot in a way where we're able to continue to support folks. You know, doula work is really based on, you know, making human connection and being with people in an intimate space. And so what happens when you can't, you know, can no longer have that space to be able to do that? And that's where, you know, JustBirth space really came in, and being able to serve as a tool to offer that continuity of care, right? To let folks know, like, hey, even though I can't necessarily be with you in the physical, I still can be with you via video chat. I still can be with you, you know, on a text line. You can still reach me. I haven't gone anywhere. And it's, you know, it's been a great tool. And although we're primarily focused on New York and Northern New Jersey, you know, we've had folks who have tapped in from all across the United States, as well as sometimes internationally. We've gotten folks who are like, hey, like, I have a question, you know, and we'll, you know, go to the knowledge base and answer as best as we can, and or we'll look it up to be able to provide the necessary resources so that they can get the help that they need in their respective areas.
I mean, I wholeheartedly agree with everything that Chanel said, and you know, there's just no question that if you're uninsured, underinsured, on Medicaid, just life got a lot more complicated navigating pregnancy during COVID for so many reasons. And one of the things that I did want to add is, and all of you I'm sure are familiar with, is huge upsurge in sort of mental health related issues for pregnant people, both prenatally and postnatally. And we saw that in Kenya, we saw it in the States. I feel like that's a sort of an I mean, people sort of recognize it as a problem, but we don't have enough solutions around this. And this, I think, really speaks to the importance of having, you know, folks who you can reach out to and be able to talk, or not necessarily, because it's really hard to get a hold of a therapist or a psychologist, you know, whether or not you're insured, you know. So maybe that's just one thing to add. I guess in Kenya too, we also saw disruption in actual services of essential maternal health services, although that's a little less relevant to the audience here in the States, you know, where hospitals were actually closing down to sort of prioritize COVID care. And so it made it harder to sort of get into facilities if you were a pregnant person or, you know, had a newborn. So maybe I'll just stop there.
Yeah, thank you. And I will pass it over to Andrew if you wanted to translate that. But the question is, how has COVID impacted your work, and what adaptations did you need to make as a result?
La pregunta es cómo afectó COVID en su trabajo y qué adaptaciones hicieron en Guatemala. Mario, está mudado.
En el caso de Guatemala se centró el problema más a nivel urbano. A nivel de las comunidades, indirectamente fue algo como, ¿cómo se llama? Más, digamos, con menos intensidad en relación a que la gente se conocía. Esto favoreció en las casas maternas porque indirectamente la gente tenía miedo a ir a los hospitales y prefirió buscar las casas maternas.
Where we work, COVID was an urban problem where the urban was more intense for COVID, but in the rural areas, it was less of a challenge, though our staff noticed an increase in usage of our CASA maternas because people were afraid of going to hospitals, or they didn't have access to the hospitals, like Nick was saying.
Thank you. Yeah, and I think that you all kind of touch on a really important part of just adjusting access to meet the needs of the community. And even Nick and Chanel with the kind of telehealth access that you've created. I think that with COVID and what we're seeing now a lot with creating emergency plans, it's really important to address those needs. And so just want to say kudos to everybody here in the ways that you all shared your work. And this is for CASA Materna. This was mentioned in the chat, but it says, not sure if whether you mentioned it, but how long can a mother stay in CASA Materna before and after birth?
Una pregunta del chat fue, ¿por cuánto tiempo puede quedar la mujer, la mamá, en la casa materna antes o después de su trabajo de parto? Cuidado.
Se quedan 12 horas después del parto.
Up to 12 hours normally after labor.
Thank you. And another question is, what lessons learned can you share from your work collaborating with governmental entities? And this is a question for everybody in the group.
En español, la pregunta es, ¿qué lecciones han aprendido trabajar con el gobierno?
Sí, manifestamos nosotros de que muchas veces los paradigmas que manejamos con el gobierno son un poquito contrarios. Entonces nos ha costado que ellos comprendan que un parto respetado debe ser en relación a los valores de la mujer, y eso es lo que a veces nos ha costado trabajar con ellos.
For us, one key challenge has been the different paradigms of how government work at the facility level versus the community level, where we try to emphasize the mother and respectful and humanized births versus the traditionally trained medicalized births. Creates a lot of tension for us.
Interesting. I can speak to the work that we do in Kenya. In the US with Birth Compass, we didn't interact that closely with the government. The state was really busy dealing with COVID themselves. And so we, kind of parallel tracked a little bit, but stayed in close communication with them and made sure that folks were kind of informed of the work that we were doing. But in Kenya, as I mentioned before, our work is sort of very closely linked with our government partners. It's happening in government health facilities. And the health system is a little different there in the sense that most parents are seeking care in government health facilities, so it's particularly important. But I think, if I were to think about our government partners who are phenomenal folks, really committed to, like here in the States, folks who are working for government and working in maternal health, they're incredibly committed to the work that they're doing, have made a career out of it and are passionate about this work. I think, sort of acknowledging challenges with access to resources and helping kind of meet them where they are in terms of both providing and synthesizing data. So really creating an approach that's really more about co-ownership and co-design than just like, hey, we're technical assistants and we're going to tell you the best way to do things. So, a lot of our programs have really been sort of initiated and kind of designed in partnership with our sort of county health partners in Kenya.
I can totally agree. We haven't necessarily worked, sorry, that's my son. We haven't necessarily worked with the government in terms of this project, but on other projects such as like Medicaid doula reimbursement and how that kind of intersects, that has been a problem where, trying to get government entities to understand the community's role in community-based projects and how that translates to being able to support in efficient and effective ways. I think a lot of times community-based organizations are called upon to answer questions and give solutions to problems, and yet those solutions are then oftentimes not really taken into consideration or not used at all. And we find ourselves back at square one. And so I know a lot of our work has been centralized on really lifting up the voices of community members and those who are community-based organizations, because they do have, they hold the solutions to the problems and really being able to support their respective communities in meaningful ways.
And if I could just add on to that, Cure America has worked with NCDHHS and other entities during COVID, and in Guatemala and in Kenya with governments. And I think that there's a lot of knowledge about listening to the community. But what I heard from community members was, we don't want to be listened to anymore. Don't ask us for questions, because what's the point? We got work to do. We're busy. And if it's not going to be taken into account, it's more of a checkbox. We asked the question, and it's not actually power shifting. Then the communities get that. The leaders, the moms, the experts on the front lines in North Carolina and around the world understand that. And so there is a little bit of this distaste for that community-based or community involved. And actually, we're pushing more of this idea of community-driven, where it's really like the community is leading, they're in charge. The mom is the protagonist. Is this great theme that Mario and Juani talk about. And I think that I will never forget when this midwife and nurse told me, don't ask me any more questions, I'm busy. Because she didn't care. It was going to be totally disregarded. She knew that. So.
Thank you all. I think that you all touch on a really great point of just really including community members as key partners and as the decision makers in a lot of these models that is being created. And so thank you for sharing that. We have 1 more minute. And so I saw that there was one question in the chat that Nikki were able to answer. There was another question right here for you, Chanel. And that's, are you opening for other doulas outside of New York or New Jersey to be able to join and help?
Not at the moment, but our hope is to be able to do that soon.
Great. Well, thank you all for joining us again. We will be sharing the information to this presentation. So we'll be sharing out the slides after this, as well as contact information from our panelist speakers. Just want to thank everyone for joining us, Chanel, Andrew, Mario, and Juani. And I hope you all have a great rest of your evening.
Great work, everybody. Thank you.
Thank you.
Thank you. Have a great night.
Gracias.